Good morning. Good morning and welcome. We are very glad to have you here this morning to talk about strengthening Medicare for 2030. I'm Alice Rivlin. I'm the Leonard D. Schaeffer Chair in Health Policy at the Brookings Institution, and I direct the Center for Health Policy here. And my happy job is to welcome you on behalf of Brookings and the Health Policy Center and the Economic Studies Division and everybody else at Brookings. This meeting is a joint venture with the Schaeffer Center for Health Policy and Economics way out in California at the University of Southern California. It is not our first joint conference. Some of you were here last October when we had a joint conference, a very lively one, on the cost and value of biomedical innovation, which dealt with pricing and coverage of breakthrough drugs. But we have been planning this conference on the future of Medicare for quite a long time. My friend Dana Goldman, who directs the Schaeffer Center at USC, and whom you'll hear from in a few minutes, and I, and Paul Ginsberg, who has a foot in both camps, have been working together to plan this conference. Paul is the Norman Topping Chair at USC, and in which he was installed last night, and also a non-resident fellow at the Brookings Institution. This conference will kick off a 2-year joint effort between the two institutions to work on how to modernize Medicare and meet the challenges of the next few decades, and from which we hope to have some really practical interactions with policymakers and some policy action. Medicare, as you all know, celebrates its 50th birthday this year. It's been a hugely successful program over that period. It has changed the experience of being old in America. It has financed care for millions who would not otherwise have had it. Along with Social Security, it has reduced poverty, anxiety about medical expenses, and it's helped the elderly and the disabled to live longer, less painful, and more productive lives. But we are not here to talk about what Medicare has accomplished. Others are doing that this year all over the country. We're here to talk about its future. And we chose to look at what the world will be like in 2030. 2030 used to seem like a long time in advance, but it's only 15 years from now. But we chose it because it is a time at which the whole baby boom generation will be eligible for Medicare. And so we will start with focusing on 2030. What will it be like then? How many people, how healthy, how wealthy or not, what resources, et cetera. It's a mixed picture, and we will turn to that in just a second. And then we will go to what the policy options for the future might be: eligibility and benefits, payment reforms, choice, and competition. So it is now my pleasure to introduce none other than Leonard Schaeffer to make a few remarks on behalf of the Schaeffer Center at USC.
Thank you, Alice, and let me add my welcome to all of you for being here this morning. I'll try to be very brief because we have some excellent panels. We want to get to them right away. I do want to say, though, how pleased I am that Brookings and the Schaeffer Center are working together on these important issues. However, I have to make two formal disclosures. The first is that I am on the board of Brookings, and I established Dr. Rivlin's chair. And I am also on the board of USC, and I established Dr. Goldman's chair. Second, I was administrator of HCFA, now CMS, many years ago. And for the record, I want to state that when I left HCFA, everything was in perfect shape. There are people here in the room who will witness that. Those were the good old days. Well, actually, that wasn't quite the case. When I joined HCFA in 1978, we were already concerned about how to ensure that Medicare was both well-managed and we were able to control costs. There was also a dawning realization that the ability to collect and integrate data to analyze utilizations and costs would grow over time. What we didn't anticipate was the resistance to turning that data into information that could be used to improve medical practice and inform better health policy. And we're still, I think, dealing with those kinds of issues. Now, the description of the conference, as Alice said, says that, and I quote, "Instead of reflecting on historical accomplishments, this event will look to 2030. I certainly agree with the forward-looking agenda and its emphasis on modernizing Medicare. I've been concerned for quite some time that healthcare costs are driving our accumulated deficit, and that is having a negative impact, or has the potential for negative impacts on our economy and on our national security. This conference suggests that many of our best health policy and economic experts are focusing their work on solving these problems, and that's good news. I was told a little bit different story about why 2030 was chosen as the focus for this conference. First, it's the date by which the youngest of the baby boomers will turn 65. It's also the year that the Medicare trustees project that the Medicare Hospital Insurance Trust will become insolvent. However, I'd like to add another, and in my opinion, a far more important issue, and that is I intend to be around in 2030 and using Medicare, and I would appreciate it if you guys would fix it up so it still functions well then. Thank you very much.
Thank you both very much. It's been a real honor and privilege to work with Alice on this project and in the other projects. And my name is Dana Goldman. I'm also the Leonard D. Schaeffer Chair and Director of the Schaeffer Center at USC. And what I want to do is talk a little bit about what 2030 looks like for Medicare. But in order to do that, I first want to show you the share that Medicare is going to consume of GDP over the next 20 years. And many of you are familiar with forecasts like these. This is a projection the CBO did in 2007, and Medicare as a percent of GDP is going from about 3%. It's more than doubling to 6.5%. Now, you might say this is an old projection, so let's take a look at what the actual data show. And actually, we're going along. CBO should be commended. They did a very good job with their forecasts. So here's their 2014 projection. And as you can see that now they're projecting that Medicare spending will only consume 4.3% of GDP by 2035. And you know, these are small, these may appear like small differences, but there's about $5 trillion in the gap between those two. And so the question becomes, is there something wrong with the way CBO is doing their forecast? And the answer is no. I think, you know, they've been quite successful, as you saw from that earlier experience. The point is that there's a lot of uncertainty in various ways that are driving Medicare. So we're going to talk today about the demographics that are driving the program, and Leonard hinted at those. We'll talk about population health, which obviously matters. We'll talk about healthcare use and technology. And then there are issues like benefit generosity. So CBO, part of the reason when their forecasts go start to diverge is because the program has either been expanded in terms of eligibility, or maybe we added something like a prescription drug benefit or something like that. And then finally, of course, reimbursement and payment policy matter. So for this first panel that we're going to do this morning, we're going to focus on the first three, and then I think as the day goes, we'll hear more on the latter half of what's driving this. So let's talk first about the demographics. And in some ways, this is the most obvious part of what's going on. Here you see the racial and ethnic makeup of Medicare beneficiary population in 2010, and here's what it looks like in 2030. The big difference, of course, is that the increase in the Hispanic population that we're going to see. Now, you might ask, so why does that matter? Well, it turns out Hispanics have larger families. It may mean that more capability of a family to assist elderly people. Maybe it means something for long-term care. I don't think we fully thought through the expansion of the Hispanic population for these projections. The other issue that we're grappling with is the change in education. So in 2010, in the Medicare population, 21% of the population had less than a high school degree. That's going to shrink, and in fact, you'll see that 62%, a majority, will have had some college, and we know that education is tied with health in ways that I think will be discussed later. And so the bottom line also is that the distribution within the elderly population will change. This is what the population pyramid looks like for people age 65 and older. There'll be 40 million beneficiaries. There were 40 million Americans age 65 and older, which is close to Part A enrollment because it's nearly universal. Here's what that population pyramid looks like. But the bottom line is the number of beneficiaries is going to increase by 27 million. So we're going to see more Hispanic representation. We'll see the population better educated. We're going to also extend the right tail of the distribution. So right now, for example, the number of people over age 100 is relatively small, and it's always usually there's some sort of party when someone gets there. But we're going to see relatively large growth in the centenarian population. And so you might think that the average age of the Medicare population will rise. But actually, because of the incoming cohorts from the baby boom, the average age will not change. But the point is there'll be dispersion. And so I think that kind of summarizes the key demographic changes. But let's look a little bit about the underlying population health, because we're all worried about that. And one of the areas we have the most concern about and people are talking about is the distribution of obesity. If you look in 2010, about 28% of the population was obese, depending on, you can see the differences by class of obesity, but that's going to rise to 47%. And the real concern, by the way, is not the overweight so much, because actually a lot of the diseases in older populations are associated with diseases that are associated with wasting. And so being overweight can actually be protective at older ages. But this severely or morbidly obese or extremely obese, that category is growing quite rapidly. And there's also good news. We see less smoking. So if you look at the fraction who are current smokers, who are current smokers, it's going to decline from 11% to 8%, and the fraction who've ever smoked from 57 to 48%. So we know that will have effects on the population. And so we can forecast what the prevalence of chronic disease looks like, and you would expect that there'd be more disease in 2030, and you see it. We see a lot of hypertension, but especially the increase in diabetes, 15 percentage point increase in diabetes. So. The other point, though, is not just single disease, but the prevalence of multiple conditions. And so we're predicting that 40% of the population will have 3 or more chronic diseases. And this puts a challenge on the model that we have, and I'll come back to this later, which is a single disease model. Let's go to this doctor to treat my diabetes. Let's go to this doctor for my lung disease. the seeing of specialists. And so the question becomes, can we use geriatric care? Can we provide comprehensive services that'll address the constellation of illnesses we're going to see in the older population? And I think that poses a challenge on the supply side. But the net effects here really can be shown if we look at life expectancy. And so the way to read this graph is it shows life expectancy at age 65 for someone who's 65 in 2010. And they can expect to live 17.7 more years. But we also worry about the quality of that life. And so what we've shown here is the number of years that are spent in a disabled and non-disabled state. So we called 11.4 of those years they're healthy and 6.3 are disabled. Now the goal for public policy isn't just to increase longevity, or the goal for our healthcare spending for that matter. The goal would be to increase the red and shrink the black, so to speak. And what you see though is the projections don't look so promising. You're increasing life expectancy for men by about a half year or more, but most of that, there's going to be a lot more disability. And if you look at women, you see a similar trend, an expansion of the amount of time they'll be spending in a disabled state. So these, again, are raising warning flags. I also want to talk a little bit, this will come up in a minute as well, about the equity of the gains we're going to see in population health. We worry a lot now about income inequality and wealth inequality, but it's interesting to think about health inequality as well. And without going into too much detail, one thing you can do is ask which part of the income distribution is going to gain the most over these 20 years in terms of life expectancy. So what you see here is the data for men who are who are poor in the lowest income quartile, so the lowest 25%. They're going to gain just under 2 years of life expectancy over this period. But if you look at the highest income quartile, they're going to gain about 4, and this gap in life expectancy, which is kind of like an earnings gap, is about 2.4 years. For women, the gap is similar. It's about 1.8 years. And if you think to some of the basic statistics here, which is if you look from birth at a black American who has not finished high school versus a white American who's college educated, they have about a 14-year difference in life expectancy. That's about the difference between, say, Estonia and the United States. And so if you think about the fact that we're going to be exacerbating that potentially, it puts a lot of tension in the social fabric. And so it's something I'll come back to at the end as well. So the summary for the health changes, though, we're going to smoke less, but we're heavier. There'll be more chronic conditions, and we'll be living longer, but spending more time with disability. Now I want to talk about healthcare use and medical technology. And one way to summarize healthcare use is to just look, and we're interested in Medicare spending, obviously, is to look at the net present value of how much Medicare is contributing to healthcare use for someone who is age 65 in 2010. And that lifetime benefit, so to speak, is about $131,000 in net present value terms. In 2030, it's going to go up to $223,000. Okay, so we're going to be spending a lot more on each beneficiary over their lifetime. And this in part reflects not only that life expectancy gain, but also that increase in disability. And again, I want to point out the disparities. So you might say, who's getting that increase? And I think here's where policy, we need to be careful, because it turns out that most of those additional benefits are going to high-income people. And it comes back to what I said about life expectancy. They're getting older and you're paying more over time. And so the question about the progressivity of the program is going to come up. Finally, I want to talk a little bit about medical technology. You all know that medical technology is a driver of healthcare spending. But I want to talk about what it does to these trends and sources of uncertainty. So here you see that we're unlocking the secrets of longevity genes. And, you know, some of you may be familiar with the biomedical evidence here. So it turns out one of the most overwhelming relationships in biomedicine is that if you take an animal, and you can use whatever animal model you like, and you reduce their caloric intake by about 40%, you can actually increase their life expectancy by 60%. And there's no drug that does that right now, but it turns out they've found some drugs like rapamycin where they can imitate that behavior. The problem is if you give the rats just a little too much, they die. So it's not quite ready for prime time yet. But the private sector has started to explore this. So this is Larry Page and Art Levinson. Art Levinson was the CEO of Genentech. Larry Page was the founder of Google. And they have a company now that's looking at anti-aging, Calico. So you know that there's at least some potential here. So this is not the pie in the sky that we used to think about. So we actually looked at what it would do to Medicare population if we realized some of the promising evidence in the biomedicine. And we compared it with these kind of disease model. That is, for a long time, and currently, mainly, our R&D is about we're going to cure heart disease. We're going to cure cancer. It hasn't been we're going to unlock the secrets of aging. So if you look at the non-disabled population, 65 and older, here's our baseline scenario. And here's what it's like if we were to delay cancer. That is, we'd reduce the incidence of cancer by 10%, which is a big deal, okay? And here's what it is if we do that in a similar effect in cardiovascular disease. But here's what it looks like if we do what the animal models are telling us with delayed aging. So what you see there, it's kind of summarized in a table on the right, but you know, we could be seeing an increase in population size of 12 million above what anyone is forecasting. Now, it's funny because when I come to Washington, there's a ton of hand-wringing about this graph, but in California, everyone's excited. I don't know if it's because you get a lot more years in the sun or what, but the bottom line here is this is potentially a boom to society. But as I said, figuring out what to do about this technology is not easy. So for example, suppose Calico is successful and they come up with a pill that you actually take when you're healthy and it keeps you healthy. Is that covered by Medicare? I mean, you know, Medicare typically doesn't cover supplements. Usually we wait till you're sick in order to give you a pill and cover it. And suppose it's not covered by a pill then. Suppose it's not covered by Medicare. What does that mean for these gaps in life expectancy that I was talking about before? Because you can bet that Larry Page is not going to give it away free the way he does search engines. So the point is that, and here's what that would do to Medicare spending. I'm just going to show you, point out that Medicare and Medicaid, and I'm just going to say that it could increase Medicare and Medicaid spending by something like $250 billion a year if that is fulfilled. So the point is there's enormous amount of risk. So let me conclude by saying that Medicare costs are going up due to a combination of factors: demographics, disease, functional status, medical technology. It's generally easy to forecast the baby boom population. It's a little more uncertain to forecast what the health trends are. They're affected by behavior and other things. And this is the most risky part, and we need to be able to come to grips with how we deal with all of these things as we go forward. And the other point is that absent reform, benefits are going to skew towards those in the upper end of the socioeconomic and income distribution. Thank you. So, it turns out that our next speaker, Gary Burtless, is sick, so I get to fulfill a long-held dream of mine and serve as a senior fellow at the Brookings Institution. And I'm going to present Gary's slides. And I won't do as good a job as you can imagine, and I'll be much briefer, which maybe that's a good thing. And then we'll finish the panel. So I think, but it follows nicely on what I was talking about. I talked to you about the potential for health inequalities, and Gary's work for a long time has been concerned with income inequality, and in particular, what we can do to help people who are at the left tail of the income distribution, that is, the poor individuals. And so what you see here is a very nice historical slide that shows the percent of Americans who are living below the poverty line by different age groups over a long period of time. And so in 1959, almost more than 1/3 of people aged 65 or more were living below the poverty line. And what you can see is the dramatic decline in elderly poverty that occurred in the late 60s and, of course, has continued today. And obviously, that's Medicare, Medicaid, and Social Security. They've been, and it shows the dramatic effects of these programs in terms of protecting those who were the most vulnerable elderly. And you can see that we haven't done as good a job, so to speak, with people aged 18 to 64. Those that are in the blue, we've had some protections in the 60s, but that's tended to be flat, and in fact maybe on the rise a little bit. And so another way to say this is to show how real income has changed over these periods for different groups. So I present this from the bottom. So the 50th percentile, what it shows here is people in the median, people at the median income. And what it shows are the income gains by age of household. So, and I hope I'm getting this right, but if you look, so the 47 to 49 category is a household led by someone who's 47 to 49, and the 80 plus is a household led by someone 80 plus. And what it shows for the median groups within those age groups, how much has income improved? So if I said the median elderly-led household, or think of it as the median older American, their income's improved 47% over this period, whereas the median household led by a 47 to 49-year-old, their income's only improved 9%. You can also ask, let's say, what has happened to the poor in those groups? So if you look at the older-led households, their incomes have improved since 1979. But the households led by younger people, their incomes have fallen. So the point is that this is getting more dispersed for the non-aged, whereas for the aged, we're kind of compressing. We're doing better for the bottom in the group. And you can see here also what happens at the 90th percentile, and you can see that the 90th percentile has improved over time, and it's relatively uniform. So the bottom line is the younger, richer households have done well, and the older, richer households have all done well. But the poorer, younger households have not done well. And this is shown kind of here where you just look at the ratio of the income of the old to the young, and this is what it looked like in 1979. And so what this means is that here at this 40th percentile, an older household tended to have only 67% of the income of a younger household. And so what you've seen, though, over time is that this ratio has gone up. So especially at the lower end of the distribution. So the poor elderly are doing much better than the poor non-elderly were over this period. And of course, by 2012, we see that the elderly tend to be making more at every point in the distribution, which is a rather remarkable phenomenon. And we see that also, what this graph shows is kind of the sense that how much of this earnings for these households is coming from work. So at the 100 line, what that means is that the household, the average earnings of an older household are much higher, are coming from work rather than some other source of income. And in fact, what we see that, of course, it shows that at older ages, earnings are less important for elderly income than other sources. Another way of saying this is that when you get older, it's really annuities and capital income and all these other sources of savings that matter for your relative position in society. And the point is that the safety net, Social Security, and private earnings need to be sufficient to maintain this. And if we're talking about, as I said, ways to deal with these increased Medicare costs by cutting generosity, then the net effect of that may be to reduce these gains we've made in dealing and tackling with elderly poverty. So I think with that, that's the best I could do for Gary. I apologize. I'd like to introduce the panelists, and we'll have a wide-ranging discussion. So I'd like to invite Greg Daniel, Julian Harris, and Paul Vandewater up to the stage, and we'll get them mic'd up. And while we're doing that, you can read their immensely impressive bios in the packet that you have. So. Great. Can you hear me? Oh, great. Greg, would you like to start?
Sure. Thanks, Dana. Welcome, everybody. I'd like to pick up where Dana left off in his presentation. It was a great analysis. It's great to have some quantitative data backing to actually look at what the Medicare population and composition might look like in about 15 years. One of the big significant findings that Dana showed was that we do see an increase in prevalence of chronic conditions, an increase in life expectancy, and an increase in spending. In terms of biotechnology and more specifically drugs, that's what I tend to focus on here at Brookings. That represents two things. One is a big concern. What will the drug utilization look like in this population? But also, it's a big opportunity. We want to have policies and an environment in place where we're encouraging breakthrough, game-changing technologies that hold promise for really improving health outcomes and potentially reducing costs on the medical side. So for example, in Dana's modeling of a potential new drug that can delay aging, I suspect that would be a pretty expensive drug. I don't think we've figured out how we would pay for it, but I suggest it will be more expensive than any other drug that we have on the market. And that's fine, maybe it should be. What we really should focus on is, let's make sure that if we do have that drug on the market, who is the right patient to be taking that drug? What is the best way to take that drug? And how do we make sure that we're maximizing the opportunities of that individual drug to actually show us the benefits and actually potentially reduce spending on the medical side, although your modeling suggests all increasing in spending. So that raises the question of cost containment as well. So between now and 15 years, I think we're likely to see more of the disease model approach. If you look at the pipeline of drugs in the pipeline today, generally it takes about 10 years or more to to get a drug to market. So you can look at the pipeline now and pretty much predict what the drug utilization or drugs available on the market will be in about 15 years. And we're seeing the trend actually going towards more targeted, more specialty breakthrough therapies for rare diseases and smaller subsets of diseases. For example, we've seen just in the last year a lot of new drugs, very expensive drugs for hepatitis C, very specific new drugs, targeted drugs for cancer. We're expecting to see many more drugs to treat rare diseases. Just as an example, the number of drugs on the market for rare diseases doubled in the last 5 years. There's about 450 drugs for rare diseases in the pipeline today. So we will continue to see, I think, more targeted, more specialty disease-focused drugs that are coming at very high prices. So that brings me to, I think, some of the topics that we'll cover in later panels, but I think is particularly important for biotechnology, and that's, let's figure out a way to make sure that we're making the best uses of those technologies. Leonard Schaeffer mentioned in the beginning in his opening comments of the real importance of turning data into information. That's a critical component. We generate so much data as we use the healthcare system today, from claims data to electronic clinical data in the medical records, patient-reported data through surveys and through other instruments that physicians might give. But we don't use that data very well at all. What we need to start doing that. Drugs that go through the clinical development process answer important questions about, can this drug work in a perfect scenario? That's what clinical trials do. But when a drug gets on the market, we don't really know how they'll actually perform in the real-world setting when drugs are used in patients with multiple chronic conditions, or they don't take the dose, or physicians may not use the same dosing that was used in clinical trials, or patients are non-adherent. All of these things, we can learn from that. We can actually utilize the data that are generated as part of those routine visits to look at, okay, we have these new technologies on the market. What are the most valuable, most cost-effective uses of those drugs? Identify the patient populations that most respond, make sure we're targeting those drugs to those populations, and make sure that we have programs in place to increase adherence. The last part that I'd like to comment on, and this is really about the Medicare benefit structure, which is quite fragmented when it comes to drugs. So if I were to add to a research agenda, it would be, let's take a serious look at how drugs are treated with the current Medicare benefit structure, and look at scenarios that might get to better aligning incentives to maximize the opportunity of those drugs to increase outcomes and potentially reduce spending on the medical side. I think Henry Aaron has a paper where he suggested bringing Medicare Parts A, B, and D under the same plan. That's a great idea because right now, Part D, which is the drug benefit, is completely separate, often by a completely different plan. In that case, there's really no incentive to use more expensive drugs on the D side if they're actually going to result in lower spending on the A and B side, the medical side. So drugs that might prevent ER visits might be expensive on the D side, but could reduce spending on the A and B side. Another potential problem with the current structure is Medicare Part B actually covers drugs too, drugs that are used in physician office settings, so chemotherapy, infusions. Those drugs are treated very differently, and the payment policies for those drugs are very different than traditional drugs that are used in the outpatient setting. So one might look at that and say, well, you know, physicians are reimbursed. There's a scenario of buy and bill, where physicians will actually buy the drugs that they're going to use in their office, like chemotherapy, and sell them to patients in the form of utilizing them and then getting reimbursed from the health plan. The reimbursement is ASP plus 6%, but really what it does is tends to incentivize the use of more expensive drugs because the reimbursement is higher. And physicians are in the business of buying and selling drugs, and they don't really want to do that, I suspect. So one potential reform would be to take all of the Part B drugs and move them over into Part D. Part D uses health plans that generally do a pretty good job of negotiating prices, containing costs through utilization parameters like tiering, like formularies, and that, you know, I'm not sure if that's the best answer, but we should look at that. And then finally, for drugs that are on Part D, we don't have a lot of opportunities to pay for performance, to really align the reimbursement of those drugs to better outcomes. Rather, we just sort of reimburse in a fee-for-service model, which is reimbursing the price of the drug, but not really tying that to outcomes. So I think that's a very important aspect to look at as we move from now to the Medicare program in 15 years.
Great, thank you, Greg. I appreciate all those specific options to strengthen Medicare. I should say, you mentioned the drug would be very expensive, but there is a drug actually right now that will improve outcomes in all diseases and increase longevity, and it's relatively inexpensive. It's called exercise. So,
Right.
you know, I forgot to make that point. Julian?
Thanks. This is my first sort of outing since leaving the White House 3 weeks ago as the Associate Director for Health at OMB. So, wearing my civilian hat.
You
for
can
the
go
first time
wild
here.
now.
Go wild. I'll tell you what I really think we should do in Medicare. I should also give one other bias, which is that I'm a former Medicaid director, and so that will color some of the things that you'll hear me talk about today. Certainly from both of those perspectives, a lot of concern about that $1.2 trillion number, even though we've seen that as a percentage of GDP, it's gone from being 6.5 to 4.3%, and the significant savings that will mean over time. Very concerned about sort of the long-term landscape, and it was interesting that Leonard highlighted the overlap of the 2030 with the exhaustion of the trust fund. That actually was a 4-year extension of the exhaustion date from the prior trustees report, and so we'll see next month what things look like on that front. But there's no question that the spending remains a concern from a fiscal perspective. But I want to talk about a few other areas that I think merit some additional attention. One is long-term care, and this came up briefly in some of the other comments, but as we think about the future of Medicare going forward and we think about the relationship between Medicare and Medicaid over time, I think that there's an open question about whether or not, as we think about sort of new structural approaches in Medicare, some of the things that will be discussed later in the day, from combining Part A and B to thinking about premium support models or unified Medicare models, whether or not at some point Medicare will play a different role. There are different perspectives on that, but I think it will be an important question as we think about the program going forward. I think it's also important to think about this population of folks who have both Medicare and Medicaid, the dual eligible population. When I was Medicaid director in Massachusetts, we stood up the first of the duals demonstrations with CMS. But I think that there are a lot of questions over time as we think about both in general having an increasing prevalence of disability in the elderly population, and more broadly speaking, the under 65 duals continuing to drive a significant amount of Medicare spending. What does the future of the program look like in that context? There's some, I think, interesting interplay in our conversations later in the day about the future of Medicare Advantage and the nexus of that with the future of our payment and delivery reform models, which we spent a lot of time working with CMS on at OMB. So whether accountable care models or bundled payments, I think over time we'll have to ask ourselves and answer whether or not one or other of those models does a better job of taking care of the most complex patients. We saw that the number of individuals who have 3 or more chronic conditions will be 40%. We layer that with the increasing frequency of disability, and we have to ask, are there things that are unique about an integrated delivery system and its approach versus a health plan? Are there different kinds of partnerships between managed care, Medicare Advantage plans, and integrated delivery systems over time that will enable them to take new and different approaches? And how do those two factors interplay? I think there are also some interesting things to think about in the context of technology, and I touched on a number of these. So, you know, if we get this magic pill, and that scary curve that Dana showed us, if we get this magic pill, you know, how much will that increase our appetite for adjusting the Medicare eligibility age? Certainly, you raised some important concerns about doing that in the context of these very significant gaps in life expectancy, both based on income but also based on ethnicity. And in the short term, I think that those have informed some conversations, among other factors, about adjustments to eligibility age. But if we're having that dramatic increase over time, how does that impact people's thoughts about how that might be adjusted going forward? It was also interesting in Gary's slide when you showed sort of the curve, the downward trend of, or the increasing, sort of the decreasing percentage of people's income One of the things that was interesting in 1985 versus in the 2000s was that actually Medicare beneficiaries are actually, today's Medicare beneficiaries are actually having higher levels of income compared to some of those in the past. And so it'll be interesting to see if we actually get those kinds of gains in life expectancy, what will that mean for GDP and some of the other things that will impact the way that we think about healthcare spending more broadly. Very interesting, the descriptions of sort of the young elderly and then the sort of second half of the baby boomer population. I spent a lot of time thinking about the nexus of that with technology like this iPad that I have here. So the iPhone came out in 2007. So most of the people who were many of the people who were in the first half of the baby boomer generation will have grown up with different kinds of technology. And how will that enable them to participate in different kinds of ways, whether it's being able to take greater accountability for cost over time, being able to hold their providers accountable and their plans accountable in different ways for quality, or maybe even tools that enable them to do things like participate in exercise programs more vigorously. And so it'll be interesting to watch that trend over time. And then the last thing that I'll end with, there was some interesting note in the paper about the decreasing progressivity, and I will just plant a seed. People in this audience paid attention, but I think a lot of folks in the press didn't notice. But one of the major pay-fors in MACRA in the SGR bill was a modified version of a proposal in the president's budget to increase the contribution to the Part B and D premium for Medicare beneficiaries. And in my mind, for a lot of the conversations that will happen later in the day about the potential for a range of structural reforms, the fact that even in what is a very contentious time and space in healthcare in Washington, that such a reform was able to be achieved in a bipartisan fashion and relatively painlessly, I think it actually provides some hope that it won't take until 2030 for us to decide to address some of the challenges that we've outlined in the paper today.
Great, thank you very much. Very provocative. We'll get to it in the group discussion. So, Paul.
Thanks. I was asked to respond primarily to Gary's paper, which is what the focus of my remarks will be, but given the rearrangement of the panel, I'll be able to throw in a few comments about some of the things that Dana said, which also did indeed complement very well some of Gary's points. In Gary's prepared remarks, which you haven't seen, Gary actually refers to his depiction of the economic status of the elderly as being cheery. Now, I don't view myself as a dour person, and I'm not trying to disagree with Gary's paper, but I do think it's important to add a few caveats or a few words of caution to what might otherwise seem like this cheery picture. One of the things that Gary doesn't talk about is how out-of-pocket medical expenses affect the economic well-being of the elderly. And it's interesting that despite the existence of Medicare and all the great things that it does, nonetheless, the elderly still spend roughly 3 times as much as a share of their income on out-of-pocket medical expenses as do non-Medicare households, roughly 15% of income for Medicare households versus 5% for non-Medicare households. There's another measure of poverty which takes that into account. The chart that Dana displayed from Gary's paper uses the official poverty measure, which basically focuses just on cash income, but many, perhaps almost all of you, are aware of the supplemental poverty measure, which looks at a broader measure of income and also makes various adjustments to measures of resources and the poverty threshold. And one of the major differences in the supplemental measure is that it does subtract out-of-pocket medical expenses. If you were to graph that, and I didn't bring a slide with me, but I can imagine it, you see the same drop-off in the 60s and 70s in the poverty rate among the elderly, and then essentially a flat rate thereafter. But the most striking difference is that instead of having the elderly poverty rate be substantially less than the rate amongst children and working-age adults, the supplemental poverty measure shows poverty rates that are much, much closer for the elderly and the non-elderly. The difference between the elderly and those of working age is only about 1 percentage point, and the difference between the elderly and children is only about 2 percentage points. So I think that's an important qualification to add. Now, I was going to talk about another topic which Gary didn't mention, which is inequalities in measures of well-being that go beyond measures of income. But Dana did add quite a bit on that in his presentation. But I'd like to say a few more words on that. Dana talked about inequalities in life expectancy. A lot of, some of the earliest research on that was done by Hillary Waldron at the Social Security Administration. A lot of others since Hillary's initial paper have continued to work in that area, including Gary himself in a paper that he cites in the references in his paper. And that inequality in life expectancy shows up in a whole lot of different ways, whether you look at inequality by earnings level, inequality by educational attainment, or in other ways. But you also see inequality in other measures. One of the areas in which I've been focusing recently is Social Security disability insurance. And there happens to be a huge disparity also in disability incidence. If you look at people who are just approaching eligibility for Medicare, those in ages 60 to 64, the incidence of disability among college graduates is twice that for those with advanced degrees. If you then go to another notch to those with merely a high school diploma, their incidence in turn is twice that of college graduates. And those with the least education, those who didn't complete high school, have a disability incidence rate which is twice that of those who did complete high school. So that's still another area in which we see these disparities. I recently saw, maybe you were familiar with it, a new paper by David Wise and others, which looks at disparities in health status. And that too does show significant differences by income level. Now, one of the big questions, of course, is what's going to happen going forward. Dana presented some projections. He didn't get a chance to tell us about the model which he used to do those projections. I thought it was particularly interesting to look at his projections about the number of years of life expectancy that will be spent in a disabled versus non-disabled state without knowing about the details of his model. I mean, I would guess that those projections are related to his assessments about growth and obesity and the other chronic conditions, which he showed in another slide. That may be correct. We don't know this issue. This issue we've been discussing for a long time as we've looked forward to an increase in longevity. There's been a continuing discussion about how much of that increase is going to be sort of good years versus bad years. My understanding, perhaps not correct, is that there actually has been a substantial increase in good years in recent history. We'll see what happens going forward. I want to echo a remark that Julian made about the importance of looking at long-term care needs. That's obviously, there are serious implications for that. Financing of long-term care remains a major issue. We don't have a very good long-term care financing system in this country. Financing long-term care through additional saving doesn't really make a lot of sense, since you're likely to have, to err in one way or another. For people who end up not needing long-term care, they may end up saving or not spending much more than would be necessary. For those who do end up needing long-term care, may end up running short. So that's another area which indeed needs attention. So bottom line, I think Gary's presentation is very useful, and certainly Dana's complemented it very well. But I just want to add a few words of clarification and caution.
Thank you. we're going to do questions in a minute, but I do want to ask a provocative question. I don't want to take the thunder from future panels, but one of the issues that's coming out of your remarks, Paul, is that the outlook for the elderly is not as cheerful as we thought. In addition, we know that there are these longevity risks. I mean, if people live longer, they outlive their savings and such, and so the financial resources are potentially at risk. So the question becomes, so that's on the financial side. On the Medicare side, it's always traditionally been a very generous program. We saw the level of dollars that are going into it. Is there an opportunity to say, hey, we're not going to cover everything, but we'll give you the cash? So thinking about the $220,000 in lifetime spending, suppose someone came along and said, you know what, we'll give you $75,000 of that, and then we'll give you a less generous policy. Would we be willing to accept people buying less than Medicare now offers in return for some protection on the financial side? Anyone?
Well, I would say that follows the theory of insurance, where you want to protect against catastrophic costs, but you don't want to pay so much for your insurance that everything is covered. Like, for example, with car insurance, your policy would be really expensive if it covered every single little ding on your car. So oftentimes people opt for a policy that has a high deductible or something that they'd be willing to pay for those things as long as they have coverage when something really bad happens to the car and needs to be replaced. So I would say that I think some would go along that, but the majority of our society in terms of health insurance has opted more for desiring everything to be covered, and then not so happy with the resulting premium, but hoping that something will take care of that.
So, Julian, are we willing to get rid of the universality of the benefit, not the eligibility? That is to say, would we say that some people, let's say the poorer elderly, wouldn't get as great coverage, but they would get more income support? Are we ready for a reform like that?
So I might think of it in a different way. I think your slide and your data point about the decreasing progressivity of Medicare sort of highlights, and some of the other data points around differential benefits already that exist based on income, I think highlights the concern of thinking about this sort of with a single brush. There's no question, if your quote unquote scary graph here in DC and not scary in California, if that came to pass, I think that it would sort of change the game, right? There were a whole range of questions that are currently even more difficult to talk about that I think would become a bit easier to explore. But I would caution, I think it's important to note the impact, and I'd love to have a copy of that slide, but the impact of taking into account people's existing healthcare spending and looking at the impact on poverty trends over time before sort of making that kind of decision broad brush. I think it's also important to remember that even the current Medicare benefit, some might argue, has some pretty big gaps compared to other kind of forms of insurance, both public and private, that we recognize today, and I know that will be a part of the discussion later in the day. But I do think that the openness to consider a range of options will evolve over time, both as we get closer to a trust fund exhaustion date, but also as some of these other demographic changes continue to sort of aggregate over time.
Paul, any comments? Or?
Well, your suggestion is an interesting one, and I'm not going to give it a yes or no answer off the top of my head. But I guess I have just two reactions. One, we know at least today that a lot of people, not only elderly but non-elderly, have very, very limited assets. There's a survey that came out just recently. I can't remember the organization. I'm sure someone here does. That indicated that for a lot of people in our country, facing an unexpected medical bill of $400 would be, a huge financial setback. Now, for most of us on this panel and perhaps in this room, that's probably not the case. We can think of, with, meeting a larger deductible on our car insurance. It seems to be an eminently reasonable thing to do for the sake of getting lower premiums, but lower income people might react quite differently to that. There is a long-standing proposal to to income relate cost sharing in Medicare, and I think that has a lot of conceptual attractions. But I think we have to be, our recent experience with the Affordable Care Act and a whole lot of other recent experiences needs us to want to be a little bit careful in extending the application of income testing. Income testing on a current basis turns out to be a lot harder to do than it might seem in the abstract. So I think that would pose a lot of practical problems. But again, conceptually, it makes some sense.
Thank you. Yeah, and I think I'm going to modify my proposal a bit now and say that you can take the cash. We'll give it, not in cash, but we'll give it to you in Apple stock. So maybe that'll make it more attractive. Okay, we're going to open this up to audience questions. I think, is there a microphone that goes around? Or if not, then I'm going to ask that people stand up, state your name. Please avoid soliloquies, and I'm going to ask if you have 2 questions you'd like to ask, choose the one you think is most salient and ask just that one, and then the panelists will respond. Yes.
I'm Dr. Caroline Poplin. I'm a primary care physician, also an attorney. I work on Medicare and Medicaid fraud in that capacity. You've talked about cost. Not a single one of you has mentioned price. I guess you assume they're the same, and in a perfectly competitive market they would be. But another way to reduce cost is by pushing for lower prices on some very overpriced things, including pharmaceuticals.
Greg, did you want to respond?
Well, so that's a great point. And certainly the pricing of pharmaceuticals does, we need to take a serious look at that. I don't think that there's evidence that, we always hear that, well, it costs so much to develop the drug, and so that's a price, and I'm not quite sure that the cost in development is actually necessarily being used to set the price in most cases. So that is an important issue, but I would still argue that an even more important issue is making sure that we're looking at the total cost of care and not just sort of the technology sector, because paying more for drugs that really do work could have downstream improvements in outcomes and total spending. So I think that we should look at price, but not at the expense of inhibiting innovation. It's risky too to develop a drug and to be not sure if it's going to be approved by FDA, and if it is, even if it's going to be covered and utilized once it's on the market. So those are important aspects that we also need to consider if we're thinking about price caps, because there could be an unintended consequence of not incentivizing the right kind of innovation.
So let me add to that, because I think that goes part way. But I want to point out that the price we're talking about is the wrong price, and that's in the following sense. When I'm thinking about buying an iPad, I go to the store and I see how much it costs, and I know how much welfare it gives me, and so I decide, do I want to get this or not? When we think about healthcare, I really don't care about the price of the pill or the price of going to the doctor, in the sense that that's not the good I'm worried about. I'm there because I want to get health. So what I really care about is the price of health. Now, granted, it's nice to go to the doctor's office and read the magazines from 10 years ago, but that's not why you're there. You're there for health. And so the problem is that, and let me tell you why we get policy wrong, because we look at the price of the inputs, not the outputs. When HIV drugs came along, highly active antiretroviral therapy, everyone was really concerned because they increased the costs of treating HIV. And so there was a push to restrict access in some programs. Meanwhile, it turns out these were some of the most efficacious drugs we've had in history. And if you look at the value they created to society, it's about $1.5 trillion in the United States. And the revenues were about $60 billion. So as an economist, I say those were an incredibly good deal in healthcare. But at the time, there were protests over the high price of those drugs. Paradoxically, by the way, now it costs $1 a day to treat HIV in Africa, and so we're finally making global progress. The point is that the signals we're getting from the prices, because we measure the inputs, are wrong. So, for example, the price of an ICU stay is a lot higher than most of these drugs. And if you look at the health improvements, it's not very clear how much health we get from intensive treatment there. But because we don't pay out of pocket, we tend not to see stories about the high cost of an ICU. And yet, but if we thought about it, how much health are we getting and how much are we paying for it, we might come to different allocation decisions. Yes.
Yes, good morning. Wait in the back.
Good morning, thank you. In terms of sort of out-of-pocket costs that aren't covered by Medicare and how that fits in for the elderly, generally Medicare doesn't cover things related to hearing, like hearing aids. It doesn't cover dental for the most part. It has very limited coverage of feet issues. I think my point is that as one ages, there are certain critical functions that are generally not covered by Medicare and fall into out-of-pocket, and dental can be quite expensive, and yet the consequences for overall health are potentially quite significant because it gets into the disability issues and the functionality issues, cognitive issues. So perhaps we'll be getting into it later in the program. Otherwise, how do you look at the fact that out-of-pocket sensory sort of things really hit the elderly harder than 45-year-olds or 20-year-olds, and in the poverty line, they're less able to pay for that, like a hearing aid. You could all pay for a hearing aid. Thank you.
Paul, did you?
I agree with what you say, and that was the reason that I pointed out looking at the supplemental poverty measure, which does take these out-of-pocket expenditures into account, and one of the reasons why the elderly do spend a higher fraction of their income on out-of-pocket expenses, which includes, by the way, not just premiums for Medicare, Medigap, whatever, but also the hearing aids and the dental care and so forth, as you mentioned. Now, there are obviously a whole lot of issues. There's no one right or wrong way to look at things, but I agree with your point entirely.
Yeah, I'll just add that, by the way, I was talking about the price of health. It turns out, if you look across all the array of healthcare services, probably the most effective thing we could do is fill cavities, because it reduces pain quite a bit and it doesn't cost very much. So anyway, Julian.
So 2 quick points on that. I think so maybe not paying for the dental care, but probably paying when someone goes to the emergency room for pain, to your point. I think on the dental piece, it will be interesting over time as we're collecting additional evidence about the impact of oral health on other things like cardiovascular health, whether people are making a business case that there should be some form of coverage there. On the hearing side, the cost of some of those technologies is coming down, and so one might argue, because the cost is coming down, will that make it more likely that it will be covered or less likely that it's needed? But it's certainly a positive trend. But it's an important source of morbidity for folks along a number of dimensions, including an impact on things like depression.
It does raise a broader point for the panelists, which is, we talked about prevention of disease, and generally we're in a model where you get sick and you get treated. We have this constellation of problems, and one of the things one doctor said to me is, I've got this patient, he's obese, he's got elevated blood pressure, he's borderline hyperlipidemic. The best thing I could do for this guy is take him for a walk, but I'm not paid to do that. And so the question becomes, why doesn't Medicare should Medicare be paying for the preventive services that would maintain people in good health and that would have benefits? And I don't want to argue that it's going to reduce costs. That's an easy one. If it reduced downstream costs, of course we should cover it. But suppose it costs a little bit, but it gives people health. That becomes a more complicated question.
So this always surprises people, but costs are actually not taken into consideration for Medicare coverage determinations in the way that you might expect. I think, one of the things will be interesting to watch over time. Let's just take your example of dental care or hearing. In a number of the, for example, managed care models, certainly this was true in the case of some of the dual eligible demonstrations, people are leveraging some of their broader flexibility to cover things that have not historically been covered either in traditional Medicare or even in Medicare Advantage plans. And so we may, over time, have some additional data that might inform coverage policy more broadly, but a lot of those coverage decisions in certain cases might require statutory changes.
And I want to come back to something Greg said that's motivated by that, which is he talked about incentives for innovation. It turns out that some of the early work in delayed aging, actually, it started to follow the resveratrol hypothesis. So for those of you who know, resveratrol is the substance in red wine, and you all know that if you feed mice resveratrol, they live longer. By the way, you have to feed them the equivalent of 100 bottles of wine a day. So, drinking, it's kind of funny. But the point was they were trying to discover super resveratrol compounds. And so they wanted to do clinical trials, but because Medicare won't cover it if they give it to healthy people, and because the FDA won't let them do a trial, they ended up doing a trial in type 2 diabetes. And it didn't work. And some people have argued that's not the right biology. You want to do it in healthy patients. So is there a concern that the way that playing field is tilted against prevention, it's affecting biomedical innovation?
Yes, absolutely. And I think that you hit the nail on the head when you brought in the sort of the regulatory aspect of that. And everybody at the FDA and the biomedical scientists are used to designing clinical trials that sort of identify the patient population that is most likely going to benefit from the treatment. It's a very disease-focused system. And it's really hard to get a new paradigm of thinking of how would you design something that is preventive in a healthy population. Part of the challenge will be, well, then what is the outcome and how long would that clinical trial have to be in order to measure that outcome? And then all of the complications with then how would you pay for it and who would be willing to cover it. I think it came up with Sovaldi a little bit on just the latter part where there was a clear benefit, but for some of the commercial plans, it was, but the average length of time that people are in our health plan might be 2.5 to 3 years. The benefit, if we're going to pay really a large price for a drug that might ward off liver failure that happens 5 to 10 years down the road, why would we bear that cost when it's most likely that patient will be in a different payer system? So those are tough questions to address, but we need to.
Good, yes. Wait for the mic, please.
Hi, I'm Catherine Nilsson, a housing economist who's focused on needs for affordable housing, and most recently actually on better estimates of those needs among the disabled. But I'm asking an entirely different question. My husband died of lymphoma last August, and the fantastic support we received from friends then and since that I've received means that I've had many, many, many discussions about end-of-life issues, and my husband chose hospice, and we had a very good death. So with regard to your underlying demographic projections, who's studying changing opinions or existing opinions and the possibility of change about hospice and extraordinary desires to stay alive as far as your breathing, but not in any other way?
There was a very provocative IOM report that just came out on end-of-life care, and I urge you to look at that. I think that's going to be the basis for a lot of discussion about how we go forward, but I'm going to defer to the other panelists. Do you have something you'd like to say about end-of-life care?
So
I don't want to pressure you.
I'm going to say something that I wouldn't have probably said 3 weeks ago, but is probably wearing more my primary care doctor hat than any other. I think we have a lot of work to do for people to have conversations between, to encourage people to have conversations within their families, as it sounds like you all did, between patients and their doctors. And I think a lot of that needs to happen at massive scale before we will be ready to have a robust public conversation. There are organizations that I think are trying to facilitate that happening. I've even heard of people in sort of faith communities now starting to have those conversations, but we clearly tried and failed miserably to have a public conversation. And I don't think we're quite ready, but I think a lot of conversations in families and in small groups and communities and with doctors will be important before we sort of are ready to have a full-throated public conversation.
So I don't want to attribute any policy on the webinar to Leonard Schaeffer, but I think I heard this from him, which is that one way of starting this conversation is to have advanced directives. And if you want your Medicare eligibility, you have to at least talk about an advanced directive or opt out if you want. And you could even tie it to renewal. And do you think that would be one way to get the conversation started?
I'm not going to, I'm hearing that for the first time. I would want to think about that more. But
I'm not putting, I don't, well, I am putting you on the spot, and I should. So, I also put Leonard on the spot, so. Any other questions? Okay, well, I just want to thank our panelists. We appreciate your time, and we'll take a break now, I think, Alice. And we'll resume at what time?